Good afternoon to all participants. My name is Jeroen Kooman from Maastricht University Medical Center. I'm excited to moderate this symposium on acute glomerulonephritis and systemic diseases, which is a topic which always gives rise to a lot of discussion in the wards, which is a complicated topic. And I'm very happy that we have two excellent speakers here, Andreas Kronbichler from Innsbruck in Austria, and Safak Mirioglu from Istanbul in Turkey, who wrote a chapter in the ENEF manual, on which I will talk a little bit later. And we also have two very good panelists. First is Eleni Frangou from Limassol in Cyprus, and the other is Floyd from Preston near Manchester in the UK. And before I give the word to Safak and Andreas, I would just wanted to say that this is the first webinar on the ERA NEF manual chapter, and you might have heard on this new initiative from ERA. A lot of chapters are actually coming up and already in press or available to you. And it's an initiative specifically based at the young nephrologists to foster, let's say, understanding of complicated clinical topics in renal disease. It's a very well illustrated manual. You'll find Q&As, you will find graphs, you will find figures, and I really hope you enjoy it. And also would like to invite you to take a look after the manual, after our discussion has finished. A very important household mentioning is that we also have translation available. Please look at the globe if you need that at the bottom of your screen. There you see a globe with interpretation. If you push that, you'll find different languages of your choice, which you can use for simultaneous translation. If you don't see it directly, you might also find it under the More button. And without further ado now, I would like to give the word, I think first to Safak, isn't it, to start the presentation on systemic diseases and acute glomerulonephritis. Please.
Yeah, thank you, Jeroen, for this nice and kind introduction, for the opportunity to write this chapter together with Safak Mirioglu. It's called Systemic Diseases and Acute GN, and we have focused on a couple of particular diseases, and we have used the distinction of the different GNs based on Achim Ander's proposal into autoimmune GN, and we've discussed ANCA GN, anti-GBM disease, lupus nephritis, and cryoglobulinemia, then infection-related GN, and then, of course, a bit on monoclonal gammopathy-related GN. Clearly, when you see a patient with glomerulonephritis, you need to distinguish between patients with nephrotic syndrome and a patient with nephritic syndrome. And all the diseases we're discussing here can present, of course, with a nephritic sediment, and only basically lupus nephritis is classically considered to be a bit of a nephrotic range proteinuria disease, but it can also present, especially lupus nephritis 4 with hematuria. Then, of course, severity distinguishes these diseases. We have anti-GBM disease, the most aggressive acute disease we see in nephrology. And then we sometimes have a more chronic presentation for ANCA GN, especially those with MPO ANCA GN. And then clearly also we have dedicated some parts of the chapter on treatment. And clearly one of the most controversial ones is discussion on plasma exchange in ANCA GN, targeted therapies, but this will be definitely something which will come up in revised versions of the chapter, much more than it is right now, and a bit on clone-directed therapy. So ANCA GN, clearly we saw a renaissance of histopathology. So a kidney biopsy is not necessarily needed for diagnosis, but it's certainly needed for prognosis. So this illustration shows you that we have different classification systems. One is the burden classification, which has been published in 2010 by Annelies Burden and Ingeborg Baema. And it's a very simple classification because it subdivides histopathology in a 50% rule. 50% sclerotic lesions is a sclerotic class, 50% normal lesions is a focal class, and 50% cellular crescents is a crescentic class. If it's not classifiable, you have a mixed class. On the right side, and this has been revised already, is the ANCA renal risk score proposed by Silke Briggs in 2018, and the ACRIS has been published late 2023, last year, replacing basically GFR by serum creatinine. And this predicts by far the best end-stage kidney disease of your patient. This is really simple to apply as well. At the bottom, you see different histopathological lesions. You can see an ANCA-GN. And why does that matter? So this is just one example where I've contributed. So 145 patients with a biopsy of ANCA-GN. And you can see that these basically lesions, if you just focus on crescentic and sclerotic lesions, you can see that there is basically no distinction in eGFR at baseline. So crescentic lesions, 18 milliliter at baseline, sclerotic lesions, 19 milliliter at baseline. But if you look actually one line further down, if you look at the eGFR at 1 year, you see this massive distinction between the two classes. So crescentic class, a plus of 19 milliliter, in comparison to the sclerotic class, which pretty much remained the same within 1 year. That doesn't mean that you don't need to treat sclerotic class lesions, but it means that the prognosis of the patients is different. And you can also see, if you look at the middle, the mixed class, that you have a gain of around 10 milliliter, but the prognosis is pretty much the same as for the crescentic class. So next slide, please. And this is, as mentioned before, the revised ARRS, the ACRIS, where the authors have replaced eGFR by creatinine, and that's definitely the strongest predictor actually in end-stage kidney disease, as you can see here in the hazard ratio of 6.6, and the points actually given to this 450 creatinine with 11. And you can see on the right side that this is really a good predictor of end-stage kidney disease free survival at 3 years. If you have the maximum points of 21, your likelihood to become or to remain dialysis-free is around 20%. If you have a low score of 0 to 4, you can see that only 4% of your patients will eventually develop end-stage kidney disease. And for the other classes, you have intermediate prognosis. So treatment in ANCA vasculitis has really been refined over the past couple of years. We have one new agent, as you know, and you can subdivide treatment into phases. So induction treatment, maintenance treatment, and then, of course, long-term follow-up, which is sometimes even without treatment. Different drugs, glucocorticoids play a main role, especially in the initial phase of the therapy. And then we have avacopan, a very exciting new substance which has been approved a couple of years ago and replaces high doses of steroids and can reduce cumulative glucocorticoid exposure. Then you know that induction treatment has shifted away from cyclophosphamide nowadays, mainly to rituximab, which is considered a bit safer than cyclophosphamide. And in the maintenance phase here, given in purple, rituximab has definitely replaced other treatments like azathioprine or mycophenolate mofetil. A bit aside is the plasma exchange, and there is a lot of controversy and discussion about that, and I will come back to that later on. And on the right side, you have definitely different disease states, and what you want to achieve is to get active patients into on-drug remission and then eventually off-drug remission without actually having a huge risk of disease relapse. So ANCA-GN, as mentioned, there has been a vast majority of different clinical trials over the past couple of years. Prominent trials are definitely the RAVE trial, which actually first basically replaced oral cyclophosphamide by rituximab. One exclusion criterion was a serum creatinine over 4. So we don't really know or have very granular data on patients with severely impaired kidney function. Then, of course, the ADVOCATE trial comparing avacopan against prednisone with a reduced corticoid exposure in the avacopan group, and a very striking finding. Then, of course, the Bexivos trial, the largest trial in ANCA vasculitis with 704 patients, either having ANCA-GN and severe kidney disease or alveolar hemorrhage. Moving on to anti-GBM disease, where treatment is, as it stands, quite nicely included into three pillars. So one is actually reducing the acute inflammation. That's glucocorticoids. Most of us will use IV bolus treatment, and then the initial dose of maximum of 60 milligrams. You can taper glucocorticoids, and this is basically important to reduce inflammatory response systematically. Then you can move on to de novo antibody production reduction. That's done by cyclophosphamide mainly. We are using mainly intravenous cyclophosphamide. Others are preferring oral cyclophosphamide. And we don't really know the role of rituximab in anti-GBM disease so far. And clearly, the acute antibody reduction is one of the most important mainstays of treatment. And this is done by plasma exchange. And the proposal is to maximum exchange 4 liters or 60 milligram per kilogram body weight. There is an alternative which is hopefully coming onto the market soon. It's called imlifidase, but we need to await the phase 3 trial. Extracorporeal therapies here displayed in this figure are basically, we have two options. So one is plasma exchange, as mentioned before. The second one is immunoadsorption. The difference is that in immunoadsorption, you basically clean your own plasma and you don't need to replace fluid. So in immunoadsorption, you have a plasma adsorber where basically antibodies are eliminated and go into the waste, and usually you don't need a replacement fluid. But in reality, you also see a reduction in coagulation factors, and some of your patients will need fibrinogen replacement, especially if you perform an invasive procedure like kidney biopsy. In contrast, on the right side, plasma exchange replacement fluid is mandatory. We usually use a lot of fresh frozen plasma if the patient has pulmonary hemorrhage or was undergoing a kidney biopsy recently, and we are afraid of a bleeding complication. Otherwise, you can also use albumin as a replacement fluid. One of the next distinction is that you can, with immunoadsorption, exchange a higher plasma volume, up to 6 or 8 liters without any problems. It's not really adding a lot to efficacy, but the exchanged volume is definitely higher, and you can remove antibodies by around 75% and with plasma exchange in around 60% per session. When it comes to ANCA vasculitis, as mentioned, there is a lot of controversy. So we have 3 major guidelines in AAV. One is put together by the American College of Rheumatology Vasculitis Foundation, and they vouch, mainly rheumatologists, of course, against the use of plasma exchange in ANCA-GN, but also in alveolar hemorrhage. And they say evidence is low to high. KDIGO has been revised recently, as you know, and they now say consider plasma exchange for patients with a serum creatinine over 3.4 milligrams per deciliter, which is equivalent to roughly 300. Patients requiring dialysis or with rapidly increasing creatinine despite treatment, and patients with diffuse alveolar hemorrhage who have hypoxemia. In the EULAR recommendations, also published earlier this year, put together 2022, we said that plasma exchange may be considered as part of therapy to induce remission in GPA or MPA for those with a serum creatinine similarly over 300 to do active GN, and routine use of plasma exchange to treat alveolar hemorrhage in GPA and MPA is not recommended. A high level of evidence and a high grade of basically agreement with 95 and 90% of the participants. And why do we have this 300 micromoles? And this is based on a meta-analysis done by Mike Walsh, incorporating 7 trials and roughly 1,000 patients. One caveat is clearly that one of these trials has been actually conducted even before ANCA has been detected in 1985. So really old data, but most of the weight in this meta-analysis came from Bexivas and the MePEX trial, and both of these trials have been conducted in a proper way. So what they have found here is, if you look at serum creatinine here in the upper panel, you can see that you need to perform one treatment actually to reduce end-stage kidney disease events in 1 out of 24 patients. But if you look at 500 micromoles, this becomes much more granular. So you need to treat actually 1 patient out of 7 to actually prevent 1 event of end-stage kidney disease at 12 months. This, of course, comes with the huge caveat again, that if you look at serious infections at 1 year, that plasma exchange is increasing this risk. So you have a number needed to treat if you look at 500 micromoles of 7, but you also have a number needed to harm of around 7. So basically, what's the drawback here is that you need to consider plasma exchange in a patient with severe kidney dysfunction at baseline, but you need to talk to the patient and also tell them that the risk of serious infections is increased. And so this is my approach in clinical practice. If I have a younger patient where I would consider end-stage kidney disease as a big issue, I will talk to the patient and then decide on an individual patient basis if performing plasma exchange makes sense or not. And with this, I'm handing over to Safak.
Thank you, Andreas. I will talk about systemic lupus erythematosus and lupus nephritis first. Systemic lupus erythematosus can affect almost any organ or system, so patients can suffer from various manifestations, as you can see here. And lupus nephritis is seen in approximately half of the patients and is a very significant cause of morbidity and mortality. Once a diagnosis of lupus is suspected, patients should be classified according to the presence of different clinical and immunological domains to make a disease diagnosis and classification according to the recent criteria. And one needs to have a positive ANA test as an entry criterion. Histopathology is very important for lupus nephritis as well. In daily practice, ISN-RPS classification is widely used. The clinical course, the prognosis, and as a result, treatment generally differ between these classes. Patients with class 1 and 2 usually have mild proteinuria, but class 3 and 4 nephritis generally cause a declining kidney function, which can be rapid in some cases. Class 5 is known for heavy proteinuria and nephrotic syndrome, and class 6 shows severe scarring, which is associated with chronic kidney disease and end-stage kidney disease. I like this figure very much. It's a review paper from 2020. The kidney function declines with age, as you know, as a result of gradual nephron and podocyte loss. The average lifespan of kidneys is over 100 years, but is lower in individuals who are born with fewer nephrons or lose nephrons from an acute kidney injury episode or chronic kidney disease. A flare of lupus nephritis is basically an equivalent of an acute kidney injury episode, which results in reversible nephron loss usually and shortens the kidney lifespan. Every subsequent flare reduces the kidney lifespan further. So treatment of the lupus nephritis must aim to achieve remission, prevent future flares, delay CKD progression, and reduce morbidity and mortality. In addition to supportive care, immunosuppressive therapy tailored to extrarenal involvement is generally sufficient for patients with class 1 and 2 lupus nephritis with mild proteinuria, but active proliferative lupus nephritis is a very different story. Very recently, treatment guidelines have been updated in light of the results of the 2 major studies, Aurora and Bellicellin. Before, glucocorticoids were generally used in combination with low-dose IV cyclophosphamide or mycophenolate. Now we have 2 more options. One is to add a calcineurin inhibitor to mycophenolate, preferably voclosporin. Tacrolimus is also a good alternative when voclosporin is out of reach, but its studies are unfortunately generally limited to Asia. The other option is to add belimumab to mycophenolate or low-dose cyclophosphamide. These additions can be considered upfront at the initial treatment stage, since the remission rates in the control arms of these trials were very low, and as you can imagine, no remission almost always results in disease damage. If cyclophosphamide is used in the initial treatment phase, mycophenolate or azathioprine can be used as the subsequent agent, but mycophenolate is preferred. If a regimen including mycophenolate is used initially, the mycophenolate should be continued as the subsequent agent. Belimumab and voclosporin can be continued in the subsequent phase 2. All patients must be treated with hydroxychloroquine unless contraindicated. Renin-angiotensin system blockers should be used, and SGLT2 inhibitors can be considered in these patients. We should assess adherence to treatment always, and treatment targets at 3 months, 6 months, and 12 months must be carefully checked. If true resistant disease is present, rituximab is usually the first option. When to stop immunosuppression is still a matter of debate, but should not be before than 3 years, and repeated kidney biopsies might be useful for that kind of decision. But when to use belimumab or when to use voclosporin? Aurora trials did not include patients with GFR levels below 45 milliliters per minute, so belimumab can be used in these patients. But the eGFR levels of more than 80% of patients in the Bliss-LN trial were over 60 milliliters per minute, so experience with belimumab is also very limited in these patients. Voclosporin is preferred in patients with high proteinuria. Strict steroid tapering was used in voclosporin studies as well, and considering the anti-proteinuric effects of the drug, it's very easy to do this when you compare it to other drugs. Cyclophosphamide has been used with belimumab only, and belimumab is also preferred when extrarenal disease activity is significant. Second part of my talk will be about other causes of immune complex glomerulonephritis, namely bacterial infection-related glomerulonephritis, polyclonal cryoglobulinemia, and fibrillary GN. Bacterial infection-related GN includes mainly post-infectious GN, IgA dominant infection-related GN, and GN of other infections, especially endocarditis. Post-infectious GN generally presents with an acute nephritic syndrome, although 20% of the cases can be seen with nephrotic syndrome. The disease course of the IgA dominant infection-related GN is very variable. Cases with progressive kidney function decline with nephrotic range proteinuria are frequent, but mild cases can be seen as well. C3 levels in the serum are generally low in both of these diseases, but they normalized in most of the patients within the first month. In endocarditis-related GN, hypocomplementemia and cryoglobulins are found in half of the patients. Post-infectious GN, namely, is generally seen after the resolution of the infection and has a very sudden onset and usually affects children, but IgA dominant infection-related GN is generally associated with Staph aureus infections, and the infection is usually active when the disease develops, so aggressive immunosuppression is contraindicated in these cases. Also, endocarditis-related GN and some of the shunt nephritis and GN associated with the catheter infections is generally concurrent with ongoing infection. We usually do not perform biopsies in these patients, but biopsies may be needed when prolonged or atypical cases are present. In these cases, it should be waited until the patients are stabilized. The histopathology generally includes a proliferative nephritis and sometimes crescents with immunoglobulin and complement deposition. The treatment is generally supportive, but use of steroids for infection-related GN is a debated issue. Very recently, a randomized controlled trial involving 52 patients from Asia showed that the recovery rates were very similar in steroid and non-steroid arm, but adverse events are very much higher in patients who were treated with steroids. Cryoglobulins are immunoglobulins which precipitate at cold temperatures and dissolve when the temperature rises. Lymphoproliferative diseases and persistent immunologic activity stimulated by chronic infections and autoimmune diseases usually trigger the clonal expansion of B cells, and this clonal expansion drives the pathogenesis of the disease. Type 1 immunoglobulins, type 1 cryoglobulins usually includes monoclonal IgM, type 2 monoclonal IgM with polyclonal IgG, and type 3 polyclonal IgM and IgG. The handling of the samples is very critical here, as false negative test results are very, very common. For treatment, rapidly progressive cases should be treated with immunosuppressive agents, which typically involves a short course of steroids in combination with rituximab. Therapeutic plasma exchange can be considered when we faced with life-threatening disease or hyperviscosity. And direct-acting antivirals should be given in hepatitis C virus-associated cases once the patients are stabilized. And finally, fibrillary GN. Fibrillary GN is a very rare glomerular disease characterized by organized, randomly oriented, straight fibrils with a mean diameter around 20 nanometers. These fibrils are usually Congo red negative, but Congophilic cases are usually reported. But the Congo red negative properties, contrary to amyloid, and help to discriminate it from amyloidosis. Also, the fibril diameter and lack of microtubular structure with a hollow core helps us to discriminate it from immunotactoid. DNA JB9 has been identified as a very sensitive and specific tissue biomarker for diagnosis, but whether it is a potential autoantigen or a protein that secondarily binds to misfolded immunoglobulins is still unknown. Fibrillary GN is linked to various causes and especially commonly autoimmune diseases. In addition to conventional immunosuppressive agents, rituximab can be used for treatment, but the studies did not demonstrate a very significant effect. Post-transplant recurrence is known, but it has an indolent course. So thank you for your listening.
Thank you so much, Andreas and Safak, for this wonderful and very educative talk. I received some Q&As in the chat before giving the word to Eleni and Lauren. I would like to address one or two of them, and before we move further. The first question is whether patients with lupus nephritis on MMF, can we also give them cyclophosphamide Euro-Lupus regimen, or should we stop it? Would you like to comment on that, Safak?
Yes. When the patient is on MMF and when you want to give a Euro-Lupus regimen of cyclophosphamide to bypass the toxicity profiles of these agents, I would go with them and drop the MMF and then do the induction with IV cyclophosphamide, then turn to MMF as needed. Okay,
that's good. And another is actually whether you could use voclosporin or Benlysta during pregnancy.
As far as I remember, there is no data about the use of these drugs in pregnancy. Voclosporin can be very harmful, but we know that tacrolimus and cyclosporine can be used in pregnancy, but we do not have that kind of data, and there's no data on the use of Benlysta, belimumab in pregnancy as well.
Okay, thank you so much. For the audience, you can please type in Q&As, so we would be happy to receive other questions. But for now, I would like to hand over, I think, first to Eleni. I thought that you also were a co-author or an author of one of the papers, huh? So that's great. Do you want to, let's say, comment on the presentations?
Thank you very much, Andreas and Safak, for this excellent presentation. And I would like to tell the audience that they have written an excellent chapter that has very good clinical cases with questions and answers. To sum up mainly regarding lupus nephritis and vasculitis, I think that the highlights are that histopathology is very important for prognosis, and there are efforts to predict end-stage kidney disease. It's very important that we can now use lower doses of steroids rather than standard doses of steroids to reduce toxicity. We have the availability of avacopan, voclosporin, and belimumab. So I would like to ask, or perhaps we could discuss this. Are these new agents available in your countries? Are you widely using them? This is my first question comment. The second is, we've seen from the discussion from Andreas that he is in favor of plasma exchange, despite the disappointing results from the Pexibas. So I wouldn't challenge this, but do you prefer immunoabsorption or plasma exchange?
Let's say, shall we take the Andreas, because Safak already had a question. Then we take the first for Andreas, the second for Andreas, and then we go back to the other one for Safak.
So the first question, I think we are in a very lucky position here to have access to all the treatments. I think and most are also approved. Recently, a colleague of mine tried to get sparsentan for IgA nephropathy case that was not approved by the agency, but we have access to avacopan, we have access to belimumab and voclosporin, where we've talked about. Second point, I need to challenge you a bit here. I'm not like pro plasma exchange. I'm very neutral. I do see, a value because I think it's an acute measure. If you look at the Pexibas trial, the readout was end-stage kidney disease or all-cause mortality at 2.9 years. So I think in terms of trial design, that is suboptimal. But of course, you're right, it's a 704 patients trial, and you should have seen a stronger signal. That's correct. But if I have a young patient where I'm really sure that this patient is not at a huge risk of severe infections, plus this patient presents with severe alveolar hemorrhage, I think there is no reason to withhold plasma exchange. And the same is true if you have a real strong signature of an acute kidney failure where you want acutely to abrogate inflammation, then I'm pro plasma exchange. In other scenarios, I think for all comers, also with 300 or 500 micromoles, it's nothing I would really pursue. Individualized decision-making, I think, makes sense in this scenario. Second part of your question was immunoabsorption versus plasma exchange. This can be answered pretty quickly. There is not really good data to replace plasma exchange by immunoabsorption, although the rationale is better. There has been a recent study in France called Cinevas. It's published in Kidney International Reports. It's a report where they showed that if over, let's say, 5 to 7 sessions of plasma exchange or immunoabsorption, you have the same antibody removal. So basically, equivalent outcome of the patients if you used immunoabsorption or plasma exchange. Couple of quirky results in there as well. I do see personally, I prefer immunoabsorption because of the safety profile. But for ANCA vasculitis or anti-GBM disease, there is very limited data to favor that.
Thank you. Safak, do you have any other comments on these questions of Eleni?
Especially for the first question, unfortunately, we do not have access to voclosporin, belimumab, or avacopan in Turkey. So in many parts of the world, this is also the case. In these cases, when we need a calcineurin inhibitor, we usually go with tacrolimus.
Okay, thank you. I would like now to give the word to Lauren to comment on that. And I also know that you have also experience with avacopan, hasn't it, in the UK?
Thanks. Yeah, just to echo the similar comments. Thanks for a great presentation and a really wonderful and helpful chapter. Yeah, I guess there's such huge variation in what people can access across Europe and globally. And obviously it brings to sort of the forefront the guidelines and updated guidelines and the variation in what people can access and how useful those guidelines can be if people can't use the things that are recommended. In the UK, we're lucky we are able to access avacopan and voclosporin, and we've been using it at our centre. I noticed there's a question in the sort of the Q&A about the use of avacopan in patients with low EGFRs. We have used it in patients with EGFRs below 15 and also in those with pulmonary hemorrhage. But I think that the use of avacopan is still relatively new, and we're finding our feet with the data in terms of the longer term data as well. I wondered, have any of Andreas, have you used avacopan in those severe cases as well?
I think, below 20, as written here in the Q&A, that's definitely a very good indication. I personally have not, or I have used it in one patient who has been ESKD dependent, and he developed really significant steroid psychosis. So when I basically visited him, he told me about, psychiatry and that he has been incarcerated and so on, which is not true. So I knew he had like a steroid psychosis, and then we had to react, and I think then it makes sense as well. There are accumulating case reports largely that it's also working in end-stage kidney disease, and that there are some late responses when you use avacopan and bring patients off dialysis, which is very uncommon. But of course, there is not really a big interest from pharmaceutical company marketing it to go into this indication, which is certainly needed, as you know.
Okay, that's. I see one question in the chat, which is, I think, challenging. Is there any place for corticosteroids in patients with Staphylococcus-associated GN with biopsy findings of severe interstitial inflammation plus crescents and after infection has been adequately treated? Do any of you want to comment on that?
Well, I can go with this question. The thing is, in this Staphylococcus-associated glomerulonephritis is usually very concurrent with the infection. When the infection is adequately treated, we usually expect the disease to be resolved in the coming weeks and months. And since they are, these patients, especially in IgA dominant cases, are reported to be mostly older patients with very fragile clinical situations, I would be very careful of using corticosteroids in these patients. But of course, every situation has an individual needs an individual approach. So it may be needed, but I'm not a very strong advocate for it.
I can go with that. Although sometimes it can be challenging because it can be very severe. It's an interesting case that it serves as the Staphylococcus antigen as a super antigen. Is that correct?
Yes, it's a super antigen and usually directly activates the major histocompatibility complex 2 on the T cells, and very powerful super antigen. So it's a very strong inflammation.
Mm-hmm.
But as it's shown in the post-infectious GN study with the 52 patients and conducted in India, the infectious events and death is very, very high in patients who were treated with steroids. So I would interpret this with caution, but the side effect profile is not very good in these patients.
Yeah. Okay, I would like to come back to our panelists, actually. Are there any, we already posed some very interesting questions. Are there other questions you would like to comment on, or topics or to comment on, or pose a question to our speakers? Lauren, do you have any additional?
Yeah, I just had a question about anti-GBM disease, and obviously you mentioned that sort of the 3 pillars and cyclophosphamide being the main immunosuppression that we routinely give. I just wondered what your thoughts were in terms of the role of rituximab in anti-GBM disease, especially in patients that maybe are dialysis dependent and but you maybe want to get antibody negative for transplantation in the future.
Well, very good point. I think, Lauren, you would be also very good to answer this. So I think what we have done recently is to look at the experience with rituximab, and there have been, I don't know, 45 cases reported in the literature, so not that many. Some used it upfront and some used it as a second line, let's say after 2 weeks when cyclophosphamide plasma exchange and steroids didn't reduce the antibodies significantly. And I think the added value of rituximab in this scenario is quite okay. But I don't think it's really, you know, rescuing your patient in terms of end-stage kidney disease-free survival, but it gets patient antibody negative, especially considering, as you mentioned, kidney transplantation. For the audience, I think it's important to be antibody negative at the time of transplantation. That should be around 6 months in continuously. So it's important to get patients negative.
Okay, thanks. Eleni, do you have any other comments or questions?
Yes. So, is there any optimal duration of treatment in lupus nephritis or in ANCA-associated vasculitis? I mean, guidelines recommend in lupus nephritis to treat patients more than 3 years. Do we have any data? I mean, are we treating patients more than 3 years, forever, indefinitely? What is your opinion?
So I can comment for ANCA vasculitis. In the EULAR recommendations, we have 24 up to 48 months, but it's also very individualized. I think you need to subdivide MPO ANCA versus PR3 ANCA. PR3 ANCA has a higher relapse rate, so I think you're treating them longer than MPO ones usually. So my go-to is if I have a new diagnosis, I treat them for 2 years and then try to stop it and see if they are relapsing, they will get indefinite treatment. And for lupus, hand over to Safak.
For lupus nephritis, both EULAR and KDIGO guidelines recommend that immunosuppression should be used for over 3 years at least. But the duration is a subject of debate, and when to stop immunosuppression is currently unknown. But we know for sure that the remission and time to remission is very important, and we should also try to stop the immunosuppression first, reducing the glucocorticoids, and if it's possible to wean the glucocorticoids off the patient, then the subsequent treatment. Also, the repeated kidney biopsy can be useful for that decision, since you and Andreas call for that paper about when to perform a kidney biopsy for that kind of decisions. I don't know, maybe you want to comment on that.
I don't know if we have time to comment on that.
No, I think we can after that. Yes, I think we can shortly, because after that we have 2 minutes left. But I think that also comes back in the question. So yes, please, Eleni, and I think we could finalize with this. Let's say our statements now.
So we could, because I can see the Q&A box, we could repeat kidney biopsy as a guide to withdrawing immunosuppression in patients with lupus nephritis in remission. So up to 42 months after diagnosis of lupus nephritis, we could repeat kidney biopsy, and in patients that have an activity index that is more than 2, then we could not discontinue therapy. We could discontinue therapy very slowly, very gradually, in patients with an activity index of 0. And then you have the problem, what to do with patients with an activity index 1 or 2. And we propose that a repeat kidney biopsy can be performed every 2 years, and withdraw gradually immunosuppression only in patients with an activity index of 0, or in patients with increased chronicity index, where immunosuppression cannot offer anything more.
Excellent, thank you so much. It already answers quite some questions in the Q&A. regrettably, because I think we can, over this topic, we can really discuss for hours. And I must say, I really enjoyed greatly the conversation we heard, enjoyed the Q&As. And thanks also for excellent presentations, Andreas and Safak, and for being a panelist and also sharing your experience, Eleni and Noren. Thanks also to all the participants and the audience for joining us. And I hope we'll see you back soon when discussing another topic of the ERA-NEPH manual. Thank you so much and have a great evening.